We often think of our bones as just solid, unchanging structures.
Yeah.
But they can actually become, well, infected. It's something that can escalate from seemingly minor issues.
Absolutely. And that's what we're diving into today, a specific type of bone infection called osteomyelitis.
Right, osteomyelitis. So what exactly is it in simple terms?
Basically, it's an infection that gets right into the bone itself and the bone marrow. Think bacteria, sometimes fungi, invading that deep tissue.
And it can happen anywhere, any bone.
Pretty much any bone, yeah. And the sources we looked at mention three main ways it gets in. You've got direct contamination, maybe from an open fracture or surgery.
Makes sense. A direct route in.
Then there's spread from nearby tissues, like a serious skin infection burrowing down. And finally, it can travel through the bloodstream from an infection elsewhere in the body. Hematogenous spread, they call it.
Hematogenous. Okay, so quite a few ways for trouble to start. And our sources really cover this condition from top to bottom, don't they? From how it starts to how it's treated.
They do. It's a comprehensive look.
So our mission for this deep dive is to pull out all the key information you need for your MSRA revision on osteomyelitis. We'll break it down, make it clear, maybe throw in some memory tips. Sound good?
Sounds like a plan. Let's start with really pinning down that definition and the different types.
Okay, so definition. Infection of bone and marrow, bacteria or fungi. We've got the three routes. Direct, nearby spread, bloodstream. What about how it's classified? I saw mention of acute versus chronic.
Yes, that's a key distinction. Acute is the initial, often quite sudden and severe infection. Chronic is when it lingers, becomes persistent, maybe flares up over time.
And chronic has some specific features to look out for.
Definitely. Three key things to remember for chronic osteomyelitis are sinus tracts little tunnels from the infected bone out to the skin surface.
Like a draining channel.
Exactly. Then you have sequestra. These are pieces of dead, infected bone that get walled off. The body can't easily clear them.
Sequestra. Sounds serious.
It is, because it harbors infection. And around the sequestrum, you often get involucrum, that's new bone trying to form, kind of like the body attempting to contain the problem. It's often irregular and weak, though.
Wow, okay. Sinus tracts, sequestra, involucrum. Got it. And beyond acute and chronic, were there other types mentioned?
Yeah, the sources broke it down further based on the route. So hematogenous, that's the bloodborne type. Think H for hematogenous, often happening in kids, affecting long bones typically.
Okay, kids, long bones, bloodstream.
Then non-hematogenous, this is usually from that nearby spread or direct injury we talked about. It's often polymicrobial, meaning multiple types of bacteria are involved. More common in adults, think non-H, not from the blood, not usually just one bug.
Right, adults, direct injury or spread, multiple bacteria.
And then there's a slightly odd one, chronic non-bacterial osteomyelitis. It involves recurrent bone inflammation, flares, but a clear infectious cause isn't always found. The name's a bit debated, actually.
Chronic and maybe
Confusing. Something like that. The exact origin is still discussed.
Okay, that clarifies the types. Now let's talk about the culprits. Who are the main players causing this infection?
The number one cause, overwhelmingly, is bacteria. And the kingpin, the one you absolutely have to know, is Staphylococcus aureus. Staph aureus.
Staph aureus always seems to pop up, doesn't it?
It really does. It's very common. But it's not the only one. Other significant bacteria include Streptococcus species, Enterobacteriaceae. Those are gut bacteria like E. coli and Pseudomonas, which you often see in, say, puncture wounds through shoes.
Pseudomonas, right. And fungi, you mentioned them earlier.
Less common, but yes, fungi can cause it. Usually in specific situations like someone who is immunocompromised, or maybe they've been on broad-spectrum antibiotics for a very long time.
So their natural balance is off.
Exactly. But really, for revision, hammer home Staph aureus, and remember MRSA, the methicillin-resistant version, is a major challenge because it limits antibiotic choices.
So MRSA makes treatment tougher. The sources probably list even more bacteria, though.
Oh, yes. The full list is longer Haemophilus influenza, especially historically in kids, other strep species, E. coli, Proteus, Pseudomonas, as we said, coagulus negative staph, even things like mycobacteria, think TB and fungi. But Staph aureus is the headline act.
Got it. Staph aureus front and center. So knowing the bugs, who is actually at risk of getting osteomyelitis?
Rank factors. Super important for spotting potential cases. The sources group them quite neatly. First up, trauma and intervention.
Okay, like accidents or operations.
Precisely. Think orthopedic surgery, big operations on bones or joints, open fractures where the bone is exposed to the outside world, and having prosthetic joints or metalwork put in. Anything that breaches the bone's natural defenses.
Well, that makes intuitive sense. What's next?
Next category, metabolic and vascular problems. The big one here is diabetes, especially with diabetic foot ulcers. Poor circulation and nerve damage create a perfect storm. Also, peripheral arterial disease, poor blood flow to the limbs makes it harder to fight infection.
Right, diabetes and poor circulation are major red flags.
Then you have chronic conditions and substance use. Things like chronic joint diseases, maybe rheumatoid arthritis, alcohol dependency, and particularly intravenous drug use, which can inject bacteria directly into the bloodstream.
IV drug use, direct bloodstream access again.
Exactly. And immune compromise. Anyone whose immune system isn't working properly is at higher risk. This includes people on long-term steroids, those with HIV or AIDS.
Weakened defenses make them vulnerable.
Definitely. And finally, a sort of other category. Conditions like tuberculosis, sickle cell disease, which has a specific association with salmonella osteomyelitis, and even things like having long-term intravenous lines or catheters, which can lead to bloodstream infections.
That is a comprehensive list.
Yeah.
Try to remember all that under pressure.
Yeah.
Any tips? A mnemonic, maybe?
Well, the sources didn't give one, but we could try. How about stop DICH? It's a bit clunky, maybe, but... S for surgery, trauma, orthopedics, prosthetics. T for tuberculosis. O for other, like sickle cell catheters. P for peripheral vascular disease.
Okay, this Tito.
D for diabetes. I for IV drug use. C for chronic conditions or immune compromise. And H for hematological, like sickle cell again. S stop DICH.
Stop DICH. It's unusual enough it might just stick.
Okay.
So we know who's at risk. Now, what's actually happening inside the bone? The pathophysiology.
Right, the sequence of events. It starts with the bacteria arriving and setting up shop colonization either through that direct route or landing from the bloodstream.
The invasion.
Then the body reacts, you get an inflammatory response, immune cells rush in, chemicals are released. But this whole process, while trying to fight the bugs, starts causing damage.
So the defense causes collateral damage.
In a way, yes. The inflammation leads to bone destruction. Enzymes released by immune cells and bacteria break down the bone matrix. Pus can form, creating abscesses, pockets of infection.
Little walled-off infection zone.
Exactly. And here's a critical point. The swelling and inflammation can squeeze the blood vessels within the bone, leading to a compromised blood supply.
And that's bad.
Because it means fewer immune cells and, crucially, less antibiotic can actually reach the site of infection. It hampers the body's ability to clear it and makes treatment much harder. It's a key reason why osteomyelitis can become chronic.
It creates its own protected little niche, a vicious cycle. Okay, that makes the pathophysiology clearer. Now, if someone comes in with bone pain, it's not always osteomyelitis. How do doctors tell it apart from other things? The differential diagnosis.
Very important point. You need to rule out other conditions. Key differentials include septic arthritis, that's infection inside a joint, not the bone itself, though they can coexist.
Okay, joint versus bone infection.
Cellulitis, which is infection of the skin and soft tissues overlying the bone. It might look red and swollen, but the bone isn't involved yet. Other soft tissue infections, too.
Skin deep versus bone deep.
Also, tumors. Both benign and malignant bone tumors can cause pain and mimic infections sometimes. And various non-infectious inflammatory conditions like gout or even reactive arthritis.
Tumors.
Right?
Need to consider that.
Yeah.
The sources had more detailed lists, too, didn't they?
They did. Adding more specifics, simple trauma, like a bad bruise or even a hidden fracture. Other causes of a limp in children, gout, as mentioned, a spinal cord neoplasm causing referred pain. And importantly, an acute sickle cell crisis can cause severe bone pain that looks a lot like infection.
Sickle cell crisis, right. Good one to remember.
The key is context. You have to look at the patient's history, their risk factors, the exact nature of the symptoms, and the examination findings to piece it together.
Medical detective work again. So how common is this? What's the epidemiology in the UK?
Well, the sources say exact numbers for the UK aren't easy to pin down, but we know it's much more common in those risk groups we discussed.
People with diabetes, weakened immunity, recent trauma, or surgery.
Exactly. So prevalence is higher there. And there's suggestion that chronic osteomyelitis might be increasing, possibly linked to rises in things like diabetes and peripheral arterial disease.
That makes sense, sadly. And what about age?
There's a sort of bimodal pattern mentioned. Acute osteomyelitis, especially the hematogenous type, is more common in children, whereas contiguous osteomyelitis spreading from nearby is seen more in adolescents and adults.
Children and adults presenting differently. Useful clue. Okay, let's get into the symptoms. How does osteomyelitis actually look clinically?
The classic signs, generally include things like bone pain, often quite localized and persistent, tenderness when you press on the area. You might see swelling, warmth, and redness of the overlying skin.
The classic signs of inflammation.
Pretty much. Also, restricted movement of the affected limb or nearby joint is common pain stops them from moving it normally. And systemic symptoms can occur, especially in acute cases. Fever, chills, feeling generally unwell, malaise.
But chronic cases might be different.
Yes, chronic osteomyelitis can be more subtle. The pain might be duller, more intermittent. Fever might be absent. You might see those sinus tracts we mentioned earlier, or a non-healing ulcer. Fatigue can be a big feature too.
So, not always dramatic symptoms in chronic cases. What about specific presentations, like in the spine?
Right, vertebral osteomyelitis often presents insidiously, with gradual onset back pain that gets worse. Fever is only present in about 60%, so you can't rely on it. Watch out for any neurological signs, weakness, numbness that suggests spinal cord involvement.
Neurological signs are a red flag in back pain.
Absolutely. Hematogenous osteomyelitis in a child's long bone. Think fever, severe pain, the child refusing to move the limb, maybe localized swelling and tenderness. Contiguous osteomyelitis after trauma.
Yeah.
Often fever, pain, redness around the injury site.
And diabetic foot ulcers. You said they can be tricky.
Very tricky. Because of diabetic neuropathy, the patient might not feel much pain. So you could have a deep bone infection under an ulcer without the classic signs of redness or severe pain. High index of suspicion needed there.
Need to look deeper, literally. I also saw a mention of the Tierney-Mader classification. Sounds complex.
It's a way of staging osteomyelitis, mostly used by specialists, but good to be aware of. It looks at two things: the patient's overall health, their physiological class A, B, or C host based on comorbidities, and the anatomical extent of the bone infection, grades 1 to I, from medullary infection up to diffuse unstable disease. It helps guide treatment complexity.
Okay, classifies the patient and the bone involvement. Useful for planning. So with all these potential presentations, how do we actually confirm the diagnosis? Investigations.
It's a multi-pronged attack. You need the clinical picture, lab tests, imaging, and ideally microbiology.
Let's start with labs. What blood tests help?
Blood tests are useful pointers. A full blood count, or FBC, might show a raised white cell count leukocytosis, but not always. Inflammatory markers like CRP, C-reactive protein, and ESR are usually elevated, often significantly. They're good for monitoring response to treatment, too.
CRP and ESR up. What about blood cultures?
Blood cultures can be positive, finding bacteria in the blood in maybe up to 60% of hematogenous cases, so definitely worth doing. But the gold standard is getting a sample from the actual site.
Directly from the bone.
Ideally, yes.
Yeah.
Cultures of any draining pus, fluid from an associated joint infection, or best of all, a bone biopsy sample, either taken through a needle or during surgery. Bone culture is much more sensitive, around 90% positive, and tells you exactly which bug is causing the trouble and what antibiotics will kill it.
So biopsy is key for targeted treatment. You need to tell the lab if you suspect anything unusual, too.
Yes, definitely mention if you're thinking TB or fungal infection, as they need special culture techniques.
Right. Now, imaging. What scans do we use? X-ray, MRI?
Imaging is vital for seeing the extent of the damage. MRI is generally the best for acute osteomyelitis. It's very sensitive and can show changes like bone marrow edema and abscesses much earlier than X-rays, often within days.
MRI for early detection. What about X-rays? Still useful.
Yes, plain X-rays are often the first imaging done and can be helpful, especially in chronic osteomyelitis. You might see things like bone destruction, osteolysis, new bone formation, periosteal reaction, or involucrum, or sequestra. But, and this is key, X-rays can look completely normal in the first week or two of an acute infection.
So normal X-ray doesn't rule it out early on.
Exactly. You might see soft tissue swelling early, but the classic bony changes take time, maybe 7 days for periosteal reaction, 10-14 days or more for visible bone destruction. Other scans like CT or radionuclide bone scans have roles too, but MRI is often preferred if available.
Okay, MRI sensitive early, X-ray for chronic changes or later stages. But the cultures guide the antibiotics.
Precisely. Imaging shows the battlefield. Cultures identify the enemy.
Perfect. So we've diagnosed it. How do we treat osteomyelitis in the UK?
The core pillars are antibiotics, often surgery, and supportive care. Antibiotics are essential to kill the bacteria.
Long courses, usually.
Yes, typically quite long. Usually started intravenously to get high levels into the bone quickly, then often switched to oral once things are settling. The choice depends entirely on the culture results or the likely pathogen if cultures are pending.
And surgery, when is that needed?
Surgery is frequently required, especially for chronic osteomyelitis, or if there's an abscess, dead bone, sequestra, or an infected prosthetic implant that needs removing. The main surgical procedure is debridement.
Debridement, cleaning everything out.
Essentially, yes.
Yeah.
Removing all the infected and dead bone and soft tissue. Sometimes drainage of abscesses is needed. In a very severe limb-threatening cases that don't respond to treatment, amputation might be the only option, but that's a last resort.
Hopefully avoided. What about supportive care?
Things like immobilizing the affected limb with a splint or cast, especially for lower limbs, and advising on weight-bearing restrictions to allow healing. Pain management is crucial too.
Makes sense. And the duration of treatment differs for acute versus chronic.
Significantly. Acute osteomyelitis, if caught early and maybe needing just one good surgical cleanout, might be treated with 4 to 6 weeks of antibiotics. Chronic osteomyelitis is a longer haul. Extensive debridement is usually necessary, possibly multiple surgeries, maybe removal of implants, followed by a minimum of 3 months, often longer, maybe 6 months or more of antibiotics. Sometimes local antibiotic delivery systems are used right in the bone cavity, too.
Wow. Months of antibiotics for chronic cases.
It often takes that long to eradicate the infection from poorly vascularized bone. And antibiotic resistance like MRSA really complicates things, requiring specific, sometimes more toxic drugs like vancomycin.
So getting those cultures is vital.
Absolutely critical. Consulting with microbiology specialists is standard practice, especially for complex or resistant infections. They help choose the best drugs and dosages.
Are there standard antibiotic regimens to start with?
Yes, while waiting for cultures or if cultures are negative. For suspected Staph aureus, non-MRSA, flucloxacillin is often the go-to, maybe with rifampicin or fusidic acid added initially. If the patient has a penicillin allergy, clindamycin is a common alternative, again, maybe with rifampicin fusidic acid. If MRSA is suspected or confirmed, IV vancomycin or teicoplanin are used, often with rifampicin fusidic acid.
Flucloxacillin, clindamycin, vancomycin, the key players.
Those are common empirical choices, yes. Duration, as we said, 4 to 6 weeks for acute, at least 3 months, often 6 weeks IV initially, for chronic. And remember, surgical debridement is almost always needed for chronic cases. If surgery isn't an option for some reason, indefinite antibiotic suppression might be considered.
So a long-term holding strategy. Is there a simple way to remember the management approach?
Maybe think ABCs, A for antibiotics, B for bone surgery debridement, C for supportive care.
ABCs. Nice and simple. Okay, after all that treatment, what's the outlook? The prognosis?
It really varies. Depends on the bug, how quickly it was diagnosed and treated, the patient's overall health and immune status, and the extent of bone damage. For an otherwise healthy person with acute osteomyelitis treated promptly, the prognosis can be excellent, with full recovery.
That's good news.
Surgery and antibiotics can contain the infection in most cases, but chronic osteomyelitis can be really stubborn. There's a definite risk of recurrence, intermittent flares, or treatment failure even years later. It can become a lifelong issue for some.
So early detection and proper treatment are key to preventing that chronic state.
Absolutely. Prevention where possible, good diabetic foot care, prompt treatment of wounds, and early aggressive management are crucial.
And even if treatment is successful, are there potential long-term problems?
Yeah.
Complications.
Yes, unfortunately. Complications can include chronic or recurrent infections, as we just discussed, bone deformities if there's been significant destruction, or impaired limb function or length discrepancy if growth plates were affected in a child.
Functional impact is a big one.
It is. Then there's the risk of the infection spreading. Septic arthritis in a nearby joint, soft tissue infections like cellulitis or abscesses forming again. Sepsis, the infection getting into the bloodstream and causing a systemic reaction, is a serious, potentially life-threatening complication.
Sepsis is always scary.
And rarer things like spread to other sites, bacteria lodging on heart valves causing endocarditis, or even reaching the brain causing meningitis. Also, pathological fractures through the weakened bone, and if there's a prosthetic implant involved, loosening of that implant.
That's a pretty daunting list of potential issues. Another mnemonic, maybe, for the complications?
Let's try. How about BFIGS PC? B for bone abscess, F for fracture, I for impaired function growth arrest, S for sepsis or septic arthritis, P for prosthetic loosening, C for chronic infection cellulitis.
BFIGS-PC. Okay, another one for the revision notes. Well, this has been incredibly thorough. We've covered the definition, causes, risks, presentation, diagnosis, management, prognosis, complications.
Yeah.
Everything you'd need for osteomyelitis revision.
Yeah, we've definitely hit the key points from the sources, hopefully breaking it down like this with the classifications and those mnemonics makes it easier to recall. It's a complex topic, but understanding the fundamentals is crucial.
Absolutely. And it leaves me wondering, given how varied it can be, from subtle chronic pain to acute sepsis, what do you think is the single most critical factor for clinicians to latch onto for that early suspicion? Definitely food for thought.
It's a good question to ponder.
Well, if you want to test your knowledge further on osteomyelitis and other MSRA topics, do check out the resources at passthemsra.com and also freemsra.com. They're packed with questions and revision material.
Great resources for preparation.
Indeed. A massive thank you for joining us on this deep dive today.
My pleasure.